Welcome everyone to Perspectives in Biomarker Testing. Who are the players involved in biomarker testing? During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, and I am the VP of Program Services, and I would like to introduce our presenters for today. We would like to thank Bayer, Daiichi Sankyo, Foundation Medicine, Genentech, and Guardant for their unrestricted educational grants for today's webinar. And now I'd like to introduce our presenters. First, Dr. Jonathan Trent is currently the Associate Director for Clinical Research, the Director of the Bone and Soft Tissue Sarcoma Group at Sylvester Comprehensive Cancer Center. Dr. Trent's interests are in the clinical and translational research of sarcomas, direct care of sarcoma patients, and education about sarcoma. Dr. Trent is a prominent champion in promoting testing among his patients, and we are excited to hear his perspective today. Layla Truspaski received her PhD in molecular biology from the University of Florida and has expertise in next-generation sequencing, liquid biopsy, precision medicine, and translational research. She is a medical science liaison at Guardant Health, a company that leverages liquid biopsy to guide personalized treatments in patients with advanced cancer, and has a passion for communicating the need for comprehensive genomic profiling to identify the best treatment approach based on each patient's unique disease biology. And lastly, Dr. Keith Killian is a senior pathologist and associate medical director at Foundation Medicine. He also serves as the lead pathologist on the partnership with Genentech to develop comprehensive gene expression profiling assays for clinical trial use. The LifeRaft group has known Dr. Killian for several years because of his notable prior translational medicine achievements while working with clinicians from the NIH Pediatric and Wild-Type GIST Clinic to discover SDH deficiency in wild-type GIST patients. I'd like to now hand this over to Dr. Trent, who will begin the presentations.
Well, good afternoon or good morning, depending on where you might be. But welcome everybody to this discussion. And I'd like to really thank and congratulate the LifeRaft group for really spearheading this event, because mutation testing is really critical for GIST patients and becoming more critical every day as new therapeutic agents and strategies are being developed. And I'm honored to be here with in the presence of the other presenters who are really passionate about helping GIST patients. I'm just going to share my screen real quick. And so we started on this journey a few years ago, and the idea was really well, let me just say, we started on this journey about 18 or 19 years ago, and our GIST center and me personally have been very passionate and early embracers of mutation testing, even back then when many academic centers were not routinely performing mutation testing. We were doing it on every GIST patient that was getting a systemic therapy, and I'll show you some of the reasons why. And we've continued that momentum over the years and are doing everything we can to ensure that the GIST patients are getting the optimal therapy as the overarching goal. And here's my contact information if anybody has any questions about the presentation today. So let me just give a brief overview. GIST is a GI sarcoma, the most common GI sarcoma, but yet a rare tumor. Unfortunately, even with primary GIST, there's a high frequency of metastatic disease. And as far as solid tumor, GIST is clearly one of the leaders and most notably identified to have tumors that are driven by mutations in specific genes. These mutations determine not only the behavior of the tumor, but increasingly important in terms of therapy. Metastatic disease is treated with tyrosine kinase inhibitors, and I've listed the tyrosine kinase inhibitors that are currently, some of them that are currently FDA approved. And so imatinib has been used as frontline therapy for patients whose GIST has spread to other organs, but also for in the setting of adjuvant therapy after surgery. And that when the GIST has spread, a measure of activity that we use is called progression-free survival, and that's the median time until at which half of the patient's tumors have started growing again. And 24 months is pretty good for solid tumors, but there's a big drop off with sunitinib, only 6 months, regorafenib, only 5 months, ripretinib with performing better than regorafenib, nearly with sunitinib in the phase 1 studies and the phase 3 study that's ongoing. We don't know the data yet from that study, but in the phase 1 study, about 6.3 months. We know from all of these studies that placebos have been used. Placebos are ineffective, and we hope that does not continue in this disease. Another agent recently FDA approved for PDGF receptor mutated GIST is avapritinib, and it has a great activity at PDGF receptor exon 18 mutations, particularly one called D842V. GIST has molecular subtypes. This is expanding all the time. These are the common ones that we see in clinic. For KIT mutated GIST, exon 11 and exon 9 primary mutations are most important. Resistant mutations are most often in 2 flavors, one called exon 13 and one called exon 17. And these are becoming increasingly important to recognize. PDGF D842V is resistant to all of the TKIs listed on the prior study except for avapritinib. So understanding that molecular data is important. SDH deficiency is also a type of GIST we see where there's not a KIT mutation or PDGFR mutation, but there's loss of expression of a gene called succinate dehydrogenase. We're still developing therapeutic targets for SDH deficient GIST. We have 2 clinical trials open at Sylvester. That's how badly, for this entity specifically, that's how badly we need therapeutic breakthroughs. And then these other genes, RAF, NF1, TREC, can also lead to development of a GIST. And this is not just important to classify the GIST, but also to select the therapy. So exon 11 mutated GIST we treat with imatinib. Exon 9, we use a higher dose of imatinib. D842V, we mentioned avapritinib. And you can see that based on the molecular signature or driver mutation in the tumor, we identify the appropriate therapy for the patient. I'll skip down to the bottom and talk about resistance mutations. Exon 13 is one of the more common, and exon 17. Exon 13 mutations are somewhat resistant to many of the TKIs, including regorafenib. The data is still emerging on ripretinib. Exon 13, though, is sensitive to sunitinib. Conversely, exon 17 mutations are relatively resistant to sunitinib, but have increasing response rate and have a higher activity to regorafenib, ripretinib, and other off-label agents for this situation, such as avapritinib, nilotinib, ponatinib, etc. So I'll show you an example of why mutation testing is important. And the mutation testing can be done on an archival tumor. When we're treating patients in frontline, we can get tumor tissue from prior surgery. We can send it off to a collaborator such as Foundation Medicine, and we can get the mutation results, and that helps us understand which of these treatments to perform. So this is a patient whose tumor had KIT exon 9 mutation, and this is the primary tumor. The patient was treated at another hospital with 400 milligrams, and the tumor actually grew. It almost doubled in size. When we saw the patient at Sylvester, we increased the dose to 800 milligrams, and at the 800 milligram dose on the far right side, you can see the tumor has become heterogeneous, hypointensining, avascular, and is essentially a necrotic necrotic mass. And so this is a great response to therapy, simply by treating the patient with the appropriate dose based on the molecular genotype of the tumor. Here's another example. This is a patient with D842V, and this is from several years ago, and this patient was treated with imatinib at an outside center, and the patient progressed because this mutation is resistant to all of the TKIs but avapritinib. So when we see this patient today, we would treat this patient with avapritinib in frontline therapy and not even try imatinib, sunitinib, regorafenib, because we know they're not going to be effective. Here's another example of a patient of mine with a BRAF V600E mutation, and you can see from left to right inside the yellow circle oval that the patient's tumor has gotten smaller on therapy with the appropriate treatment. So now I'm going to discuss a phenomena that has really risen out of treating just patients with TKIs. And that's this whole concept of different patterns of progression. A patient can have a situation of and metastasis. So a patient can have a situation of oligometastasis, meaning there's only one lesion in the liver. We can remove it. There can be, at the time of progression, there can be different mutations within the tumor. So for instance, this patient's liver has multiple lesions in it. Some of them could have exon 13 and some of them could have exon 17. And it's important for us to understand these mutations at the time of progression. When the metastasis starts getting larger, we need to understand if it's exon 13 or exon 17. And we can do that by biopsying lesions, and we can send it and evaluate it for mutation testing from the tumor. Or there's newer technology that you'll hear about today called circulating tumor DNA or liquid biopsy, where we identify DNA within the blood that's floating around from the tumor. The tumor sheds DNA into the blood. That can be taken out with a simple needle, and there are increasing number of different companies that are doing this testing, and some academic centers as well. And so I'll discuss some of our experience with circulating tumor DNA. So we looked at 243 GIST patients from multiple institutions mostly, but almost 50 patients from Sylvester. And one thing that we found was that we could detect the primary mutation in the blood from the patient, and that most commonly it was exon 11, and that we could also identify PDGFR mutations as well as KIT exon 9, other KIT, and even other mutations. Now the other group, we're still determining what the significance of these groups are. And and so that's the primary mutation. When we look only at the resistance mutations in this subset of patients, and these are patients that have been treated with a variety of different TKIs, the most common resistance mutation is KIT exon 17, 57%, and the second most common resistance mutation is exon 13. Sometimes we don't find a resistance mutation, or there may be some other pathway that's potentially implicated, but that's an area of active research. And then this is just representing in the same patients from Sylvester, the mutation status that we found in the tumor. Most commonly exon 11 in our patient population. Second most common exon 9, which might be enriched for because of the resistance. And then other sites of mutation in the archival tumor from a prior surgery or a prior biopsy. So this is the mutation pattern when we test the tumor, not the blood. And I wanted to just show a little bit of data in that on our circulating tumor DNA. And so if you look at patients who had blood drawn and had the mutation testing, the ability to measure circulating tumor DNA in the blood of GIST patients is unfortunately very low with primary tumor low volume disease or patients responding to therapy. However, patients that have metastatic and progressive disease, we're able to detect circulating tumor DNA mutations about 83% of the time. So if I have a patient with a primary tumor or a very small tumor, I might not do the circulating tumor DNA mutation. I would need to do a biopsy and do the mutation testing on the FFPE, the archival tissue from that biopsy, that we can get tested on the tumor itself rather than the blood. And as technologies increase, we may be able to increase the sensitivity of testing in these situations where the results have been low so far. The patients in our study had, like I said, a variety of different treatments. And then I'm going to provide some data that's evolved out of our studies at Sylvester from collaborations with Cesar Serrano in Spain, and from the laboratory of Mike Heinrich in his models. And that is that when a patient has a primary mutation and is treated with their first line of therapy, any of these agents out here on the far left, the chance of responding is very high for all of these inhibitors. They're all very good KIT exon 11 and KIT exon 9 inhibitors. Now, when a patient becomes resistant to imatinib, the story's a little bit different. And the one thing that stands out that I'd like to point out based on this data is that exon 13 patients whose tumors have exon 13 resistant mutations are sensitive to sunitinib, like I mentioned earlier. But these other agents aren't so active against exon 13. Ripretinib is, the jury's still a little bit out on that. There's some preliminary data from the phase 1 study that it actually has some reasonable activity at exon 13, but we're waiting more experience. On the other hand, sunitinib is not very good at exon 17 or 18 resistance mutations, while these other agents all have some activity at that end of the protein in terms of inhibiting KIT kinase activity and helping patients. And so that helps us therapeutically. Another observation in our study was that there were patients that had both resistance mutations, exon 13 and exon 17. We're hoping that these patients will be sensitive to ripretinib. The data is still evolving. And then there's also a clinical trial that's been published, a phase 1 study using a molecule from Plexicon plus sunitinib in combination in order to inhibit both of these areas in the patient's tumor. Here's an example of how we use this in real life. This is a patient with KIT exon 11-9, liver metastases, progresses on a number of 4 different therapies. We do ctDNA and find an exon 17 resistance mutation, Y823D. This patient has these tumors in the liver, and then you'll notice after 6 months and after 12 months, they get a lot smaller and a lot darker on ponatinib, which is a very potent inhibitor of exon 17. It doesn't work at exon 13, and we wouldn't expect sunitinib to work in this situation. Here's another example of a patient treated who's found to have exon 11 primary mutation, exon 13 resistance mutation. Well, the patient was treated with one of the other TKIs, and it was, I believe it was avapritinib or regorafenib. But anyway, the TKI didn't work, and the patient was progressing. And this was only after about 4 weeks because the patient was having pain. And we got the circulating tumor DNA results back, found out it was exon 13, and quickly switched the patient in the hospital to sunitinib, which was very effective and has helped the patient for many years. There are some limitations to circulating tumor DNA use in clinical practice, and that's the study, although the largest one out there from our center, is small. It's retrospective. There were almost 200 patients from other institutions that we didn't have pathology confirmation. And with circulating tumor DNA, like I said, the sensitivity is improving and it's increasing, and the accuracy is improving and increasing. But there's still going to be some negatives on ctDNA from the liquid biopsy, whereas a needle biopsy will have a higher probability of getting a positive result. So there's advantages and disadvantages to both. In conclusion, the liquid biopsy is useful, it's non-invasive, and it can be used in GIST patients. The limitations I mentioned are the low sensitivity, particularly low volume disease, responding to therapy, primary tumor. Larger volume, larger tumors growing, we can detect it with a reasonably high sensitivity in GIST patients. We did look at some outcome data, and we found that when patients there was a hint that when patients underwent ctDNA testing, that their outcomes were better, possibly because we were matching them to the more active therapy. And that was hypothesis generating. And what that's led us to do is led us to start a clinical trial for ctDNA guided therapy in order to assign treatment to a GIST patient based on their ctDNA results. They would get assigned to sunitinib if they have exon 13 resistance mutation, and regorafenib if they have exon 17 resistance mutation. And we're very excited to offer a prospective clinical trial where we think we can deliver optimal therapy to our GIST patients in a very, very rational and molecularly driven way. I'd like to thank the Sylvester team, GIST and sarcoma team back at Sylvester, who's seeing all these patients and generating all of this data. And I'd like to show you what our tumor boards look like when we talk about GIST patients in the era of Zoom. This is the Sylvester team hard at work figuring out optimal treatments for GIST patients. I'd like to thank everybody for the time discussing this important topic. And I'll be happy to answer questions now at the end, or feel free to reach out to me directly. Thank you.
Thank you so much, Dr. Trent. So far, I don't see any questions. Okay, a question just came in. After having mutational testing after surgery, as well as next generation sequencing through Foundation One, I have found to have quadruple wild type GIST, no mutations. What type of research, if any, is there to determine if other biomarkers may exist?
I think looking at SDH expression would be, I think might be the next step for me. And, I don't know if it was tested or not, and which foundation panel was ordered. So maybe Dr. Killian could chime in, but SDH comes to mind as potentially the next step for me.
Yeah, great question. The first thing that comes to mind is, are you female and perhaps younger? And you may, if so, you may have the SDHC epi mutation, which requires gene expression and or DNA methylation analysis to confirm that. Looking at the aneuploidy profile of the tumor might also provide some clues if there is a missed SDH mutation, but most panels are not going to miss, that cover SDH genes are not going to miss SDH gene mutations. And there are rare NTRK fusion GISTs. I guess another question is, was it a stomach GIST? Those are typically where the SDH deficient. But as John said, just an immunohistochemical stain for succinate dehydrogenase might be the first step to follow up on subtyping.
Okay, thank you. We are going to aim to save questions to the end. So I'm going to allow Keith to go ahead and provide a presentation to us. So feel free to share your screen, and thank you so much.
Okay, can you guys hear me?
Great.
Yes.
Unmuted myself. Let me put this into presentation mode. Okay. Hopefully everyone's seeing this.
Yeah.
Thanks, Sarah, for the invitation. And John did a great job presenting the very big diversity of mutations that we see across the GIST subtypes. My talk is a little broader on cancer genomic testing in general, but it's very applicable to GIST. I'm not aware of any tumor types that have as much molecular diversity as GIST. So it is important to have a comprehensive molecular test that can accurately subtype one's GIST. So gene mutations and cancer in general, DNA is exposed to cancer-causing agents every day, and we accumulate mutations, and exposure increases these risks as well. UV light, radiation, viral infections. Many tests can pick up various HPV and other pathogens that can cause cancer. And then heredity. It's important that tests can detect hereditary mutations as well. And of course, the mechanism here is mutated genes result in altered proteins or completely missing proteins, which in turn alter key pathways that control cell growth and result in tumorigenesis. So next-gen sequencing has emerged as currently the most powerful approach to comprehensive testing for a wide variety of potential genetic defects in cancers. And this technology allows sequencing hundreds of millions of nucleic acid molecules simultaneously in one patient sample, one extract from that sample, as opposed to multiple independent individual single gene tests. So the four main types of DNA mutations, we can go through those that we want to be able to detect. So we have a lot of different genes we want to look at, but also a different variety of types of genomic mutations that assays need to be validated to be able to detect, because they all have different sensitivity and specificity for individual assays. So the first are just basic substitutions. These are typically single base mutations within the genome, such as a KRAS G12D type mutation. The second one, are indels. So these are slightly larger. These are between maybe 5 and 20 nucleic acids may be deleted or inserted. And this requires a different computational and testing strategy to see those type of events. The third are copy numbers. So these are going to be gene deletions, which we commonly see in tumor suppressor genes, such as the BRCA1 and 2 genes. The SDH, A, B, C, and D genes are all subject to deletion in GIST. Then you also have gene amplifications. This includes, for example, MYC amplification or androgen receptor amplification in prostate cancer and many other types of gene amplifications. And finally, gene rearrangements, also known as gene fusions, when we think they are functionally activating a gene through a translocation or another type of rearrangement in the genome that'll bring an oncogene under the expression control of perhaps a housekeeping gene. And so this can turn on a gene that perhaps is not normally supposed to be turned on. And that can be a very challenging type of event to see with next-gen sequencing. So when we validate these assays, we separately validate all 4 categories of these genomic events. So historically, just to give you kind of a visual of these 4 types of alterations, the base pair substitutions, this is what we used to use Sanger sequencing, could fairly readily detect these events if the mutation were present in typically greater than 25% of the cells in the sample. And then indels also can be seen with Sanger sequencing and also capillary sequencing. Here you can see we've deleted several nucleic acids. Copy number alterations historically were seen by FISH or fluorescence assays. Sometimes in situ chromogenic assays could see these as well, such as HER2 amplification and breast cancer. And finally, rearrangements. Traditionally, we needed to do a very labor-intensive fluorescence in situ hybridization assay to detect those. But now with next-gen sequencing, as I said, we can see all 4 types of these events and validate assays and determine their sensitivity and specificity for these events all in one test on a single patient sample. And beyond single genes and beyond those 4 types of mutagenic events, we also have emerging biomarkers such as microsatellite instability status and tumor mutation burden. And here we're looking more comprehensively for a genomic signature that may be impacting many genes, even non-specifically in non-cancer genes, especially to see what is the mutation burden in this cancer, providing evidence for DNA repair deficiency, for example. And then there are some biomarker claims that have FDA-approved therapies that are independent of tumor type and specific gene mutation status. And here, for example, with tumor mutation burden, if we're above a certain cutoff in the tumor genome, and for TMB, we need to be looking at typically greater than 1 megabase of DNA to make that measurement. So again, we need a broad and fairly quantitative look across the genome to detect these emerging biomarkers. So just to give a review then, and John also gave great examples of this in GIST, we can look at a patient's tumor as a first line look to develop a treatment plan with tumor boards. We can prevent contraindicated therapies, such as with the PDGFRA mutation. We can avoid trial and error treatments, and these also can help inform prognosis. Then following first line treatment with progression or relapse, resistance mutations may emerge, which can guide next steps in the treatment plan and predict response to immunotherapies with some biomarker testing. And then in refractory disease, we can clinical trial options based on the genomic profile, explore tumor agnostic therapies or therapies that worked in a different tumor type where we may have seen a similar mutation. And then finally, in many cases, just obtain peace of mind that, that all options have been explored. So I'm going to just give 2 practical considerations now for real world testing. I'm a pathologist, so I look at many samples every day. And when we're testing a patient's sample, we're looking at the tumor nuclei %. And this also is a regulated measurement on patient samples for test validity and sensitivity to find mutations. And we need a certain percentage of tumor cells in the total biopsy. So the TN% is the total number of tumor cells divided by the total number of cells in the sample. And below here, we have a GI biopsy with some normal benign epithelium to the left, and then there's some inflammation down below in the stroma, and then we can see some malignant glands percolating down below the epithelium. And this, I estimate that this particular field of view is only about 5% tumor. Many cancer tests are validated to require 20% tumor. But the molecular pathologist, and one thing we do on every sample is mark the tumor so that in the lab we can further enrich the tumor cells away from the non-tumor cells and get up above 20%. Some biomarkers actually need greater than 30%, and even some alterations like copy number changes really benefit when you get up closer to 60%. So we're on every sample, we're looking for opportunities to really zoom in on the tumor cells and glands to improve our detection even further. Another consideration, and something that we can control when we design these tests in the lab, is how many reads we do, how much money we spend just accumulating data from the sample, because our sensitivity for mutation detection in a population of normal and tumor cells really depends on how deeply we probe into the sample. And you can see by the time we get up to 300-fold coverage, we have 98% sensitivity. But even with 100x coverage, the sensitivity may only be 35%. Again, this depends on the tumor purity. As I showed on the last slide, if you had 20% tumor purity versus 50 or 90% tumor purity, that would shift these curves somewhat. And finally, I wanted to conclude with a note on overcoming limitations of NGS. And so with the pathology specimen itself, we're constantly striving to improve our enrichment of the tumor cells from these samples and validating those methods so that we can boost the tumor purity. And also I mentioned we can do deeper sequencing, spend more money on sequencing reads. It increases test cost, but that's really the whole trick with plasma tests and cell-free DNA is sequencing very deep into the plasma to detect very low-level mutations present in the plasma. And then on the other end, on the biomarker side, one limitation of DNA-based NGS is we're looking right here at the Watson-Crick level of DNA, the helix, but on top of the DNA, we have the epigenomic profile, including DNA methylation, chromatin structure, and these are areas that are very ripe to explore and develop biomarkers, which will further improve sensitivity for early tumor detection and even disease monitoring, and even understanding pathogenesis, such as in some wild type tumors, being able to detect phenomena that may not be reflected at the Watson-Crick 4 nucleotide level in the DNA. So that concludes my talk. I'll turn it back to Sarah.
Amazing. Thank you so much. I learned a lot from this presentation, and I even have some questions if we get time to it in the Q&A. We're going to go to our last presentation. So Layla can We're going to have Keith unshare his screen and
Yeah,
have.
let me see how I can do that. Give me 1 second, please. How can I? Oh, there. Okay. Okay, there you go.
Amazing. Thank you. Okay, Leila, thank you so much for participating today. We are looking forward to hearing your presentation.
Sure. Can you see my screen?
Yes.
Excellent. Well, thank you all so much. My name's Layla. I'm a medical science liaison at Guardant Health, which is one of the liquid biopsy companies that are currently available commercially. I'm really glad that Keith gave such an in-depth background of what next generation sequencing is, how it works, what it helps to identify. Essentially, what we're doing with liquid biopsy is that same process, but we don't need a tissue sample. So we're just doing this off of blood. And essentially, sorry about that. Essentially, what we're identifying through a liquid biopsy is that when your advanced stage tumor is growing and there's cellular turnover, if there's necrosis, if there's apoptosis, which means that there's cells dying in the solid tumor, that actually releases the tumor's DNA into the blood. So we're able to capture this tumor DNA that is being released from that cancer and do that same type of sequencing that Keith just presented to us. So utilizing cell-free DNA or circulating tumor DNA, we can use those terms interchangeably for the purpose of this conversation. We're actually able to look at what's happening, not only in just one piece of a tumor. So if you'll remember from the tissue assay, we're taking an FFPE sample, and that's something that has been taken either from surgery or from a biopsy, and we're looking at a small piece of a small corner of the tumor. Now, the benefit to liquid biopsy is that we're able to look at that same, primary tumor site, as well as the metastatic site. So as the tumor grows and metastasizes, there's genomic changes that are occurring as well. And so we're able to kind of look at the full picture with liquid biopsy. And there, of course, were some limitations that we'll discuss as well. But essentially, when we take that cell-free DNA out of the blood, the same types of sequencing that Keith has just mentioned. So we can look for the single nucleotide variants, the indels, the fusions, copy number amplifications. We can also go beyond that to look at other biomarkers such as tumor mutational burden, microsatellite instability, even homologous recombination deficiency. And what we can use this for is to help identify the mutations that are occurring in the patient and match those mutations with potential therapies. So like Dr. Trent mentioned, we can look for those various KIT mutations and PDGFRA mutations to see which exons those mutations are occurring in and which line of therapy may be most beneficial for the patient. There are some limitations to tissue testing that liquid biopsy is here to help overcome. In my opinion, liquid biopsy and tumor biopsies are very complementary to each other. There's going to be times where one of the assays will pick up a mutation that the other has missed and vice versa. So not to say that everyone needs to go and get liquid and tissue testing, but they are very complementary assays. Some of the barriers that liquid biopsy can overcome are the long turnaround times that it could take for some sequencing labs to get your results back. So if you think about the time it takes to get a biopsy, have the pathologist, send that out of the lab, send it to the sequencing lab, get that on the sequencer, and then get your report back, that could take sometimes up to 3, maybe even 4 weeks. A liquid biopsy result can be provided in 5 to 10 days, depending on the type of panel that is chosen. Tissue also has a finite resource. So we heard from Keith that there's a lot of different staining processes that have to happen to not only diagnose the tumor, but to genotype it, to characterize it, et cetera. And if there's a chance that we've exhausted all that tumor and there's nothing left for comprehensive genomic profiling, liquid biopsy could be a viable option for that. Upon disease progression, if the patient doesn't want to undergo a second biopsy to see how the tumor has changed, liquid biopsy could help to fill that gap as well. And considering the practice, the physician, the staff, everyone that has to coordinate sending out a tissue sample, getting that result back in and interpreting that, a simple blood draw is a little bit easier to manage from that perspective. And so we think of a liquid biopsy as just a simple blood test. A result will get returned back to you within a week, maybe 2 weeks. When should we actually use this test? There's a lot of research being done in this space of not only the utility of liquid biopsies in early stage or cancer screening, but there's a lot of data out there now in the advanced cancer stage. So for Guardant 360, even Foundation Medicine does have a liquid biopsy as well. The recommendation for advanced stage tumors are to use this at diagnosis. So perhaps if there's not enough tissue available to genotype and identify that first-line therapy, this could be another solution to help identify the gene mutations that are present in the tumor across solid tumors. These tests are actually FDA approved for advanced tumors at this point now. Another utility of this test is at disease progression. So if we wanted to identify any potential acquired resistance mechanisms to see, okay, the patient has progressed on this first-line tyrosine kinase inhibitor, they've acquired this mutation, that means we can now target them with the second generation drug. That could be very important information that you could get from a blood draw rather than having to go through another biopsy. A third way that this is currently being used, and there's some new research and publications that have come out, is actually utilizing the test to predict how a patient is responding to therapy. So there's some really beautiful studies that have been presented recently about looking at the change in ctDNA from baseline before a patient is being put on a new therapy at an early on treatment time point. The change in that ctDNA, whether it increases or decreases and by how much, is actually reflective of how the patient is responding clinically, both on scans and predictive or prognostic of the progression-free survival and overall survival as well. So some of the benefits of liquid biopsy, and I wanted to keep this very high level as a general education for the group. There's a very fast turnaround time. So after the blood is received into the lab, it's typically a 5 to 10 day turnaround time to report out the next generation sequencing results from the liquid biopsy. It's a non-invasive assay, so it's only a blood draw. We don't need to go in and get additional tumor. And this can typically be performed either in the office, at the oncologist's office, or via mobile phlebotomy. So I know at Guardant Health, we offer mobile phlebotomy at no cost to the patient. Someone will come to your house, draw the blood, and take care of shipping that off, so you don't have to travel to an office to get the blood draw. It's very complementary to tissue testing. So as Keith mentioned, with the tissue next generation sequencing, there's very high concordance between liquid biopsy results and tissue next generation sequencing results, especially for identifying those driver gene mutations in advanced cancers. And there are times where liquid biopsy might pick up something that's missed on the tissue testing, and vice versa. Tissue testing may pick up something that's missed via liquid biopsy. So that's why I say that they're complementary assays to be used together. Liquid biopsy has actually been presented and published as a non-inferior assay for genotyping, especially in the case of newly diagnosed non-small cell lung carcinoma. Another benefit of liquid biopsy is that it can capture tumor heterogeneity. So we're looking at the DNA that's being shed from those active metastatic sites, as well as the primary tumor lesion as well. So you kind of get a bigger picture of what's happening across the whole, as well as being able to identify acquired resistance mechanisms when on a targeted therapy. In addition to identifying genotyping information, some more broad biomarkers that can be identified are tumor mutational burden and microsatellite instability, which could inform patients who may be eligible to receive an immunotherapy-based option. And this is another non-invasive way to identify a patient's response to therapy. And sometimes we can actually look at that response before scans, or if scans are maybe equivocal or not very informative, or there's some spots that look a little strange or fuzzy, the changes in ctDNA could help shed light onto what's happening on those not clear scans. I pulled this from a paper that I just read recently about GIST cancers and how the biomarkers are improving. And I just highlighted here some of the cases where liquid biopsy could be beneficial. So as Dr. Trent mentioned, there's various KIT and PDGFR mutations that are reflective of response to various TKIs, such as imatinib or sunitinib or even avapritinib. And so the liquid biopsy is able to cover the mutations that are associated with each of those therapies. The other types of mutations that could be relevant are NTRK fusions, BRAF, NF1, RAS mutations, etc. to identify other potential targeted therapies or even drug trials that the patient might be eligible for. Something that this test might not be great at is for looking at the activity of SDH. So that's something that's typically done from an immunohistochemistry or a protein-based assay to look at whether that gene or that protein is present and active. There are other ways to look at the activity through next generation sequencing, but we're not actually looking at proteins in this test. So there are going to be some limitations that I want to discuss with you as well. The first is that for a patient's liquid biopsy to be successful, the tumor needs to be shedding DNA into the bloodstream. That happens when there is, a lot of tumor burden, there is a lot of cellular turnover, etc. If a patient has slow growing or indolent disease, there might not be as much tumor DNA shed into the bloodstream to be able to capture and to sequence with high fidelity. And if a patient's actively on therapy and responding to therapy, that's going to be suppressing the tumor shed from being released into the bloodstream. So there are optimal times to try to grab that tumor shed. And that's at diagnosis before the patient begins therapy. At disease progression, when the patient is no longer responding to therapy, there's clinical signs of progression, you can typically identify ctDNA at that point. This isn't intended to diagnose an advanced cancer. So as Keith mentioned, where he uses in pathology the slides to diagnose and able to identify the type of cancer that tissue came from, that's not the case with this type of liquid biopsy assay. Maybe in the future, there will be additional opportunities to be able to diagnose cancers, but the utility of this test at this point is really for comprehensive genomic profiling and to guide treatment or identify clinical trials that the patient may be eligible for. Also, liquid biopsies are currently widely DNA based. So we're not looking at a lot of RNA for gene expression or for fusion analysis. And we're not looking at protein activity or expression such as SDH or even PD-L1, et cetera. That's the end of my presentation. I wanted to be able to stop to open it up for further discussion and would also welcome any comments from Dr. Trent or Keith as well.
Thank you for your presentation.
That was great. Great job. Thank you both.
So we did have a number of questions that came in. So one of them is, what is the accuracy of mutational testing? Is there a difference between different laboratories in the outcome of testing? And I just want to add to that, because I know that Keith had mentioned about tumor purity. Is that perhaps the reason why retesting needs to be performed?
Yeah, well, that is a big difference between liquid and solid tumor testing, is that we can actually see in the microscope what the tumor burden is, what the tumor cellularity is. And our assays are validated for 20% or greater tumor content. And we do, enrich the sample in the lab to get to 20%. So most samples we are able to test if there is any tumor visible on the slide, or at least we'll try. But yeah, so the sensitivity is always based on a minimum tumor purity of like 20%. And then the laboratory determines how deep they sequence systematically the samples. So at Foundation, I believe the latest numbers I've seen are greater than 98% sensitivity for mutation detection once we hit that sort of 20% tumor content. But it is important to keep in mind that the test sensitivity is dependent on the presence of tumor DNA, if in the plasma, or tumor cells in the biopsy.
Dr. Trent, do you want to comment on just some of those differences? Why? there might be, like, if there's any differences between the labs, because that has been a question that has been asked to us, like, why this lab, why that? You know, are the panels different?
Yeah, I mean, I think that there's some differences in the way that they're tested, but when you're looking for KIT mutations, KIT resistance mutations, I'm pretty sure most of the labs are all sufficient to be able to do, to make those determinations. We like to do circulating tumor DNA at the time of progression in our GIST patients. Unless they have a solitary lesion or they're having a tumor nodule resected. And then we'll send that for the tumor tissue testing. And then we usually do the tumor testing at baseline also.
Okay, so I'm going to ask a question that comes up quite a bit at the LifeRaf group from our patients, and that's just the challenges with insurance companies paying for the tests. And so we wanted to know, to ask, have you seen this, and do you have any advice on how to overcome those challenges? And I'll just give you an example of a question that came in where a patient had a progression with an exon 17, and you had noted in your chart that Sutent doesn't target that, yet the insurance company is requesting that the patient take that rather than what was suggested by the physician. So what is your advice, Dr. Trent, in these situations, as they seem to be coming up more frequently among our patients?
Yeah, that's a very good question. And the reality is that we do not have prospective data. We don't have a prospective trial where patients are assigned treatment based on circulating tumor DNA results that shows that it's feasible and that it, whether it improves outcomes or not. We just don't have that data. We have retrospective series that suggest that that is the case. And so what we do in that situation is we get all the information together that we can. So we get any abstracts from ASCO or from CTOS, we get any publications that might suggest optimal treatment. And then we share that information to the insurance company, and we try to get the right agent, try to get them to approve the right medicine based on the data that's available. We go through the appeal process. And then if insurance continues to deny it, then we actually ask the pharmaceutical company if they'll give us the medicine for free. And sometimes they'll do that. And so generally that's our approach, but you're right, it is an increasing problem. And it's such a big problem that's one of the reasons we developed this clinical trial, which is the first prospective clinical trial to enroll patients and assign therapy based on their mutation, rather than just randomly assigning therapy. I know it's the first trial in GIST. It may be the first trial in solid tumors, really, to do that in a prospective fashion.
Okay, I'm just going to ask one more question. So it seems that in recent years, we're finding more mutations such as fusions, et cetera. So we wanted to know, Layla, if circulating tumor DNA is adaptable to these new findings as more research comes about.
Yeah, that's a great question. And absolutely. I mean, liquid biopsy is like any other sequencing assay where it just depends on the underlying technology and how that's designed to cover those specific mutations or fusions. It's absolutely adaptable. We're, typically right now we're looking at exonic regions that are important for cancer-related genes, and especially those that may have a therapeutic option available for them. But there's a lot of ability to expand and adapt liquid biopsies. And I would actually welcome Keith for his input as well, since he probably has more experience with the actual development of the assay.
Yeah, I was just trying, Foundation Medicine also has a liquid test, which I focus mainly on tissue testing, being a pathologist. But yes, you totally can see fusions, rearrangements, copy number changes all of that in liquid biopsies based on the design of the test and what it's designed to detect, what it's validated to detect.
Okay, great. We had a lot of questions. I want to thank